better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everyone. I'm Dr. Liz Turner from Untethered Airway Health Center, and welcome to this week's episode of No One Told Me, the Airway Health Connection. Today, I wanted to dive into the differences between guided growth appliances or prefabricated appliances and custom fixed expanders. I wanted to talk about some of the differences in relation to a post that came up the other day. I had a patient on Instagram share a before and after, and I got many comments saying, "Did you use this? Did you use that?" I wanted to talk about some of the differences in how I use all these individual appliances for a truly personalized approach for patients. So if we think about it, we know that our skeletons are getting smaller, and with that comes a challenge in fitting all of our adult teeth into our dental arches, our jaws. So what we're trying to do and trying to accomplish is more space for the adult teeth. But also, as a side effect, when we widen the roof of the mouth and make more space for the lower jaw to fit within it, we increase the oral volume and truly the volume in relation to the airways. So the nasal passages widen because the roof of the mouth widens. The roof of the mouth is the floor of the nose. We widen the upper jaw for the teeth to fit, and as a side effect, the nasal passages widen too, internally. If we create more space in the mouth for the tongue to fit, we also create more space in the airways posterior behind the tongue. And that's where the conversation of sleep quality and sleep disorder breathing comes in. What we at Untethered do is really manage the dental manifestations of underdevelopment of the jaws, and as a side effect, we'll often see improvements in sleep and breathing quality. We know that these things are multifactorial, and that's where we really use an evidence-based, individualized approach to treatment. So when we think about what guided growth appliances are, they're prefabricated silicone appliances, and there's a variety of different brands out there, and many of them you've probably seen on social media or the internet. You have providers that offer them. And really what they do is they create a force on the teeth by putting the teeth into a position that postures the lower jaw slightly forward. So they have a mandibular or lower jaw advancement quality, which can improve the airway size when they're being used. They also put pressure on the teeth. And since teeth have a ligament around them, each tooth has its own ligament. What it is kind of like a distraction process for the bone. It's why people with osteoporosis will lift weights to get stronger. There's a bone generation capacity by putting the bone under load. And so we have the ligament stimulated by biting against something. So maybe that's, you've probably heard baby-led weaning is good for jaw growth, and it is. It's the same concept in the sense that we're putting the pressure into this silicone appliance, creating pressure and force on the periodontal ligament. And with that, the bone is stimulated to grow. So is that truly expansion? Well, there are providers out there who say that they have imaging, CBCTs and the like, that show that there's a skeletal split of the craniofacial sutures. Well, I'm just not one of those providers that has the imaging to back up that claim that we'll get true skeletal expansion. So I do see in my practice that I'll get rounding out of the arch form. I'll get increased width of the jaw. And is there some dental tipping and movement involved? Likely. There is, I will say, also dental tipping and movement involved with a custom expander. So it's not like I'm saying, oh, what I do is always superior. It's that I'm being honest in the fact that teeth move too through the bone. I would say that in my practice, I use these appliances in a way to help develop the arch form to allow for more predictable, customized expansion. And what do I mean by that? Okay, so babies 0 to 6 months, non-nutritive sucking using a pacifier is normal. It's really actually very positive because it helps improve the strength of the oral facial muscles. In the literature, it helps reduce the risk of SIDS. And really, that suck reflex is integrating around 4 to 6 months. So we want them to have good engagement and extension of the tongue. It helps drive the lower jaw forward. And from there, I want to transition them to a appliance or a teether that's more positive for jaw growth and development. So I'll often use what's called a myomunchie. I use the myomunchie as a precursor to these prefabricated guided growth appliances. This is where it gets tricky because a lot of it comes down to cost and compliance. So why do I use a myomunchie before I use a guided growth appliance? Well, I do it as a test because if I tell a parent that I'm going to expand their child's jaw with the use of an appliance that requires 100% compliance, like the kid has to elect to use it. I don't want to overpromise on something that I can't deliver on. So I use the myomunchie as a precursor, a test to see if they can tolerate the more cost or the stronger appliance that allows for that compressive force to get the jaws and the teeth to move. So Myomunchie, it's a silicone-based habit appliance, and they're out of Australia, and they're a great product. They're quite a bit more expensive than the knockoffs you're going to see on Amazon because you'll see similar U-shaped silicone appliances with these little kind of extensions within them. They're sometimes even marketed as like toothbrushes. So the Myomunchie is a really well-made appliance, and it's the one that's really been able to back up their quality, and it's one that I haven't seen deteriorate on patients if they're using it appropriately. If a child's taking it and like ripping it like a chew toy, of course it's going to break down. But if they're using it appropriately for anywhere from 5 to 15 minutes a day while they're reading books, watching a show, it helps desensitize the oral cavity and helps set them up for kind of the next phase of jaw growth. If we think about it, a baby doesn't go from a baby to over the course of 6 months the size of a 20-year-old. Growth is incremental. And there are different parts of our bodies that go through growth at different times. The upper jaw really is growing rapidly through the first 6 years of life, and then it slows down. And it does continue to grow into the early 20s, but it's very, very slow. Whereas the lower jaw grows rapidly for the first 2 years, and then it stalls out and then it picks up its growth again in like prepubescent years. So it's weird how they're staggered like that. So we need to make sure that we're accommodating the growth as it's occurring. And that's why I tell people that it's not always one and done when it comes to this stuff. Like maybe you had a tongue tie release, it doesn't mean you won't need braces. Maybe you had an expander, it doesn't mean you won't need braces. There's all these different phases of growth and alignment that we go through to help optimize a human, especially because we have all these other factors at play that are interfering with our growth. So we go from pacifier to myomunchie to say they tolerate a myomunchie really well and they're 3.5, 4 years old. They've got the beginnings of a deeper bite, meaning their top teeth are covering their bottom teeth 80 to 100%. Okay, that's where these removable growth appliances can be really helpful. And one of the biggest differences between that and a custom appliance, especially if we're thinking about time under tension, the removable appliances are really only in place for a certain period of time throughout the day. You can't have a child wearing a removable appliance because they can't speak, they can't eat, they can't swallow liquids from a cup. Like they need to exist as humans. We can't just like force them to just clench on this thing 24 hours a day. So the idea, the way that they're often prescribed by many of the companies is 1 hour per day and overnight. Well, the hard part is if you have a child who's really busy and a family who's really busy, that may not be realistic. It's also that if there is any nasal blockage at all or tonsillar adenoid enlargement, these children may not be able to tolerate these appliances. And for us forcing them to wear something because there's a cost associated with it, we could actually be doing them more harm. So again, that's why I use the Myomunchie. I use the Myomunchie to determine, are they even candidates for this next phase? Or do I need to make another referral? Because if they're 3.5, 4.5 years old, they can't tolerate a Mayo Munchie. How do I expect them to tolerate something that's even bigger and takes up more space in their mouth? If they're having a behavioral reaction, they're just not tolerating it. Okay, do we really want to waste the family's time and bandwidth when we have a more targeted approach? If they're gagging, if they're really uncomfortable, if they're having a sensory reaction, shouldn't we make a referral to an OT at that point instead of forcing them to do something that's really uncomfortable and could be further triggering and worsen the sensory reaction? And finally, if they're unable to tolerate it because they truly cannot breathe through their nose, we need to be making a better interdisciplinary referral to somebody like an ENT. Because think of it like this, and this is where my bias comes in a little bit because I treat so many babies with reflux. Babies are born with enlarged turbinates, meaning the nasal passages are enlarged, they're inflamed. And then as a distraction happens from a good latch and good nasal breathing occurs, those turbinates shrink and they become obligate nasal breathers. Well, say there is something like a tongue tie, low tone, poor latch quality, and a reflux pattern persists or continues, those tonsil and adenoid prolific lymphoid filtration tissues are already at a point where they're inflamed. And likely by one, they're not at a point where they need to be removed. Because what happens then between 2 to 6 is those tissues get larger and larger as a way that the immune system is learning to protect itself. So as the natural immunity is building, we expect tonsil and adenoids to get bigger. Well, if they're already the beginning stages of enlarged, and then they get even bigger than that in a confined space because the arches and the airways are constricted, then we have a situation where surgical removal of those could be extremely beneficial. And listen, if you're listening to this and you're like, she's pro surgery, I'm pro better breathing. I'm not pro surgery. I'm pro whatever helps your child breathe better and get the neurological they need, neurological support and rest they need in the formative years of life. So if that involves tonsil and adenoidectomy, I am all for it. My son, for example, had to go through tonsil and adenoidectomy. He even needed his adenoids out twice because he had other inflammatory factors. My daughter, no tonsil and adenoids, small round of expansion. Different kids, different situations. And that's where, even within your own household, you could have children that are on a different track. So it's important to remember that in an individualized approach and really appreciating everyone's individual anatomy and the risk factors surrounding them is extremely important. So why else could tonsil and adenoids be enlarged? Why else could the nasal passages be enlarged? Environment. Some of us have mold in our homes. We know that pollution and microplastics play a role in inflammation now. There are certain controllables that we just can't control. And if the tonsil and adenoids are overtly enlarged, that's one controllable you as a parent have, especially if they're at an age where expansion may not be either accessible or appropriate. I have many families that come and see me. They've got a 14-month-old and they say, "Can you do an expander?" And I say, "Goodness, we don't even have any teeth." So, absolutely no, we cannot do a fixed expander on a child with no dentition because we're using the teeth as tools. Plus, in what world am I going to get a 14-month-old to cooperate with me for a true skeletal expander?
You've heard us talk about how airway health impacts everything from sleep and behavior to feeding, facial development, and overall systemic wellness. Now we've created courses to help you take the next step. Whether you're a dentist ready to transform your practice or you're an allied provider wanting to deepen your airway expertise, the Untethered Way has education designed for you. Our Foundations of Airway Dentistry course gives you the complete clinical and business framework to integrate airway-focused care into your practice. You'll learn diagnostics, treatment sequencing, case presentation, and the systems that help you build a sustainable, thriving practice while offering life-changing treatment. We've also made this course available to allied professionals, and we're blown away by how many IBCLCs, speech therapists, oral-facial myofunctional therapists, dental hygienists, and even physical therapists and occupational therapists have asked for this training. We also offer advanced surgical training on frenectomy protocols across all ages, infants, children, and adults. The training is available online as well as live intensive courses with hands-on learning. These are the courses that we wish we would have had access to when we were first learning about airway dentistry. They help you condense time into helping changing lives and change the financial health of your practice. You can learn more and enroll now at the untetheredway.com. The link is in our show notes.
So that's where other things like the myomunchie, the guided growth appliances, occupational therapy, build the muscular strength, all that comes into play. So back to why we use the myomunchie. We use that to determine can they nasal breathe. If they can nasal breathe, they're progressing, they're using this. Maybe they're using it 5, 10 minutes a day while they're reading books. Okay, great. We can do a prefabricated appliance. Maybe we're trying to unlock that deep bite. Maybe we're trying to round out that arch form a little bit. Maybe they really don't have any other symptoms and we're trying to wait until the 6 year molars erupt because this child is actually doing really well. We just know that they don't have enough dental space because we need spacing between baby teeth. And everybody is all about like, what's the appropriate timing? The appropriate timing is really where a child is in the developmental stage and where the symptoms are. And I co-manage a lot of these cases with ENTs who are like, hey, I can't help them right now. These aren't surgical cases, but they're symptomatic. There's nasal resistance. And would you help them? And so when we have other medical professionals coming into our field and saying, hey, you can use the teeth as tools and help this child be healthier. But we have people in our profession who are completely on the other side. Why would you ever do something like that? It's not developmentally appropriate. You can't expand a child who doesn't have their molars. Well, why not? They have a skeleton with sutures. We're not necessarily moving teeth. That's not our goal. We're looking for orthopedic expansion, not necessarily orthodontic movement. So that brings us back to developmental growth appliances, guided growth appliances, and fixed expansion. If you look at this stuff on the internet and on social media, there's a lot of fear mongering that goes into it. And that's where I hope this clears the air. We're pro all the things that help people be healthier. And if that's some gentle tooth alignment when they're 7 because they don't have enough room and things are coming in a little crooked and they've got no other symptoms because maybe they had their tonsils and adenoids out at 4, great. That's awesome. But not everybody is part of that cookbook. So, say you've got a 5 year old who doesn't have their 6 year molars yet. They can't tolerate a guided growth appliance. They've already had their tonsils and adenoids addressed. The adenoids are now regrowing, and they're at risk of a second stage procedure, a second round of being sedated and having the adenoids removed. And the ENT refers them over and says, hey, can you use these baby teeth as tools to help guide the adult teeth into place? And as a side effect, reduce the risk that we have to put them through the surgery again? My answer is going to be yes. So, why couldn't we use a guided growth appliance in that situation? Well, adenoids are enlarged, can't breathe. If they can't breathe through their nose even a little bit, the chance that we're going to be able to safely get them to use an appliance that seals off their oral airway is pretty darn low because the time that it takes to make the change is so much longer. Then, here's where the fear mongering comes in, a rapid palatal expander. And I'm using quotations here for those of you listening. An RME or an RPE, rapid palatal expander, rapid maxillary expander. It's all about how quickly you do the expansion. It's actually a misnomer because we don't have to turn it rapidly. In the past, and this is where some of the literature comes in that scares people, sure, if you crank that sucker 4 times a day, if you turn it a millimeter a day, there's a chance that you could drop the nasal floor. If you turn it a 1/4 millimeter every 3 days and you allow that bone of the sutures to backfill in, you're not doing rapid expansion. You're doing tooth-borne palatal expansion. And the time that it takes for change is so much faster because you're using an appliance really 24 hours a day. You're distracting that suture apart where it's allowed to backfill in with bone. Versus with a guided growth appliance, you're putting pressure on the teeth. You are posturing the lower jaw forward, which opens up the airway, but you're only doing that for a certain number of hours per day, including at rest while they're asleep. And if that appliance falls out 2 hours in the night, or the parent says, I don't know, I'm not in there. I don't know how long they had it. Seems like they fell asleep with it, but I went in an hour later, it was out. How much time under tension are we actually getting for these children to create the change that's necessary? So, are these appliances useful? Absolutely. They really are. They're useful from a sensory perspective, they're useful from an alignment perspective. And in some practices and for some children, they're useful from an expansion perspective. But the way that we approach this is really from the more evidence driven, where we can utilize the teeth as tools using a custom designed expander to create the sutural change of not only the palatal suture, the central suture, but of the zygomatic sutures as well. And this is where, if you were to ask me what I use most consistently, I would say a customized lab developed expander 85% of the time. Because so many of us have faced an underdevelopment of our maxilla, our upper jaw, and our kids are no different. So, why do we expect that we can just completely naturally guide them out of the genetic profile that they've been born into? Not every child needs expansion, but many do. And we shouldn't just discount the fact that some have needs and others do not and say, oh, we don't do that till they're 7, or oh, we can use this one that is meant for everybody because it's pre-sized. Everybody needs a different approach. And that's where we really lean into imaging. And if you rent a car and you go to a new town and you don't get a map, how are you going to know your way around? And it's the same thing for imaging. If we have an appliance, we rent a car, we get an appliance. If we don't have a map to show us where that appliance is going, how are we ever going to expect to get where we need to? How do we have appropriate diagnosis if we don't have the imaging to really support what we're doing and look for what our end goal could potentially be, which is proper arch development? So in our practices, we utilize a lot of CBCT imaging, and I know many parents are resistant to radiation, but there's radiation everywhere. There's radiation on the airplanes you go on. There's radiation in the food. There's radiation from the sun. And if we think about overtreatment or undertreatment without imaging, you're at risk of that. And so I would highly recommend that if you're a parent and you're listening to this, if you're resistant to imaging to help guide treatment, don't be. Because you really need that to do the best thing and allow the provider to do the best thing they can for your child, which is provide a proper diagnosis and render proper treatment based on the information they have. And if you as a parent are only allowing us to look at where the teeth are and not what's under the surface, we could miss something. And then whose fault is that? It's everybody's fault. And who suffers? The child. So my recommendation is always to provide an individualized approach with imaging. It allows us to see tonsil and adenoids. It allows us to see if there are any congenitally missing teeth. It allows us to see what our end goal range could be. Everybody wants to know, how wide do they need to be? It's not always that. Sometimes it's forward, because width isn't really the biggest thing. We have anterior posterior problems too. And if we don't know where that maxilla and that mandible, that upper and lower jaw fall in relation to the skeletal structure, we may miss the opportunity to provide forward growth as well through auxiliary appliances such as a reverse pole face mask. So you as a parent, you want us to image, and it's low dose radiation. It can be one and done, though in our practice, we do offer a second scan post-treatment, though I do leave it optional because I want to be respectful of parents' wishes. And when it comes to utilizing guided growth appliances, I'm a big fan of them. Personally, I've reduced my fee of them a little bit, and that could ruffle some feathers, but I've done that because I feel really strongly that if I'm not helping a child get where they need to be, I want to be able to pivot and not have utilized a lot of a parent's finances to be able to do so. If we think about what insurance coverage is for orthodontics, it's about the same as it was 30 years ago. Same thing as dental insurance. And that's not the provider's fault. The cost of everything's gone up. Our appliances are extremely expensive. Our chair time, our staff, our clinical experience, our education, our staff, our rent, our electricity, just like the same things are happening in your homes, your groceries, your electrical bill, your taxes, all this stuff goes up. Yet the cost of reimbursement for dental insurance has gone up like $6. And maybe if you're lucky, like 500. You might be getting like 2 grand of coverage where it went up for 1,500, which it was 30 years ago. So, anyways, this is more of a conversation with big business and your insurance provider than it is with your dental provider, because at the end of the day, we're just trying to do the best we can for your family with the costs associated with it. And if we think about the cost of dentistry long term, if we don't fix underdevelopment in the jaws, it is exponential. And I say that because if you think about broken teeth, cavities, failed fillings, periodontal disease, gum recession, lost teeth, dental implants. If we think about those things, so much of the root of it can really stem from the fact that your jaws don't fit together. If your top jaw is smaller than your bottom jaw, there's no question that those teeth are under excessive force. If you had premolar extractions, if you have a fixed bar on your teeth because you have a tongue thrust because there's not enough room for your tongue, we're doing things in the dental world that we can do. We can line teeth up. But if we're not doing it on a stable, bony foundation, we're going to be in trouble later on. And you as a parent, we might not be around. Like, I'm probably not going to be around when my kids are 40. Maybe if I'm lucky. They are going to have bills associated with dentistry that could have been reduced if we just look closer at childhood development and how it plays a role in long-term stability and alignment of the teeth. If your teeth are under excessive force, they will break. If your teeth are under excessive force, you could have gum disease, recession. If you don't have the bone support surrounding your teeth to hold up your gums, the chance that there's going to be some recession, potential need for gum grafts, sensitive roots is really darn high. And we go ahead and we blame the patient. We say, you brush your teeth too hard. Or we even blame the provider and say, man, that gum graft, it didn't work. It didn't take. It didn't take because there wasn't bone to support the graft that they did. They're trying to help you make up for lost time when there wasn't any bone to support the treatment that needed to be rendered because we had no other option. So, really, if we look at dentistry as we go through our lifespan, it becomes extremely expensive. And prevention is key. So, for you as a parent, if you're listening to this, for you as a provider, if you're listening to this, you can do a service to the children that are yours or the ones you're treating if you just look a little bit closer at their alignment early on. Because just because the teeth are straight doesn't mean they're not going to be crowded later. We need spacing. We need alignment. We need to untrap that lower jaw. We need to allow for the lower jaw to continue growing as these grow at different rates. We really need to look at the details. And so for you as a parent, ask good questions of your provider. Hey, what do you want to do? I see that these baby teeth are a little crowded. They're 8, they haven't lost a tooth yet. Like these are the things that we hear every day. And we have a lot of parents that are pretty upset. I've been seeing the same provider for 7 years with my child. They never once mentioned a tongue tie. They never once mentioned that it was a big deal the baby teeth were touching. They always said, oh, the teeth are so pretty. They're so lined up so nice. Well, they're lined up nice, but there's no space between them. Adult teeth are 30% larger than baby teeth. If we don't accommodate for that, we're going to end up in a situation where we miss the growth window. And now we're lining teeth up on a faulty foundation. I use this analogy all the time. It's like you have a small lot, but you want to build a mansion on it. And you're like, let's just like cram it in there a little bit more. You can't do that. You got to make sure that the lot's appropriately sized for the house you're building. So, my recommendation for families when you're navigating between guided growth appliances and custom expanders is what's the diagnosis? What is the diagnosis you're giving me for my child? Yes, there are approaches that will create more space, but is it the space we truly need or is it dental movement? And that's the hard part. Both of these things create dental movement. The question is, how much expansion does your child need? And where do they actually need the expansion? And without imaging, that can be difficult to do. So my recommendation is to continue to ask good questions because there's so many different types of cars out there and everybody's brand loyal to certain things. And just because your next door neighbor loves one thing doesn't mean you have to love the same thing. You as a parent, you as a provider, get to make the decisions based on your philosophies and your training. And so my recommendation is to continue to ask good questions of the providers you're seeing. And as providers, look at everything available, learn everything. And of course, I teach a course in this stuff. So here's my plug. I'm terrible at sales. I really, just as a restorative dentist, I feel really passionately about what we missed. And as a restorative patient who's spent hundreds of thousands of dollars on 3 reconstructions already, and knowing that dentistry only lasts so long, so I'll likely need another one in my lifetime if I live that long, it's expensive It's really expensive. And if we just talked about prevention and alignment early on, maybe we'd be in a different situation. So set your kids up for success. And as providers, set yourselves up for success. Parents are coming in asking good questions. You could be the provider that continues to educate, to make good referrals, maybe render certain treatments, create interdisciplinary teams, create patients that are so loyal because you changed someone's life. This isn't selling dentistry, it's selling health. And that's what you're doing as an airway focused provider. So, it's not like I walked out of school and into this. I was a general restorative dentist for 8 years before like the light bulb went off. And just ethically and philosophically, I saw the big picture and was like, I gotta work on helping change lives more than just like changing a tooth here and there. And the fun part is it makes dentistry so much more fun because you actually get to do more of it. And so our course is untetheredway.com. We've got a foundations of airway focused dentistry and a frenectomy course. I look a lot at oral restrictions and how they impact jaw growth in part. But even so many of the patients that we put through frenectomy care to help them grow as much naturally as possible, just genetically, they still require some form of expansion. And again, maybe that's a guided growth appliance. Maybe that's fixed expander. Could it be a combination? Absolutely. So learn the tools, learn all the things you can. At the end of the day, we just got to help kids breathe better through the dental tools that we have. I'm not treating sleep apnea. I'm treating dental underdevelopment. And as a side effect, we can see an improvement on chronic health. I tell people there's a brain arm to this, a functional medicine arm, and a structural arm. I'm the structuralist. But because we look at all the things, because we have the imaging, because we have the before and after, because we're able to continue to monitor symptoms over time, we can make appropriate referrals when needed to those other sides, the brain arm, the functional medicine side, the ENTs to help work on the structure. So there's so many avenues. You just kind of have to develop what your recipe book is. Guided growth appliances are a part of it in my practice. But again, I will say that the majority of the expansion I do and refer for is customized, just because that's really where the evidence supports, and that's where we see the most change within a time frame that I feel more comfortable with to help a child be healthier. So with that, thank you for joining me on this episode of No One Told Me, the Airway Health Connection. I'm Dr. Liz Turner. We'll see you next time.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.